And now I'm talking to Tony Duffin, the Director of the Ana Liffey Drug Project. Tony, how's it going?
Good, thank you. Thanks, Darren. Good to be here.
Okay, Tony, could you tell me how you got involved working in this sector, please? And before we go into present-day issues of drugs and drug addiction, can you tell me about the history of the Ana Liffey Drug Project, please, up until now? Like, I know the overall story of how illegal drugs came to Ireland is not a small story, and I'm aware that you work with people with problems with alcohol as well, but feel free to talk about it for as long as you want.
Okay, thanks. Well, firstly, I was working in London. My parents are both Irish, and so I was a member of the London Irish community. I suppose I had an interest in I suppose all families, all communities are affected by addiction, not least of all, I suppose, the Irish community in London. So I had an interest. But it wasn't until '93 that I really started to work with people with particular around the issues of say homelessness, addiction, and mental health, particularly those areas. And I was made, unfortunately, or fortunately, whichever you look at it now, I was working as a photographer in Christie's Auction House in London, and I was made redundant. I was a young man, and there was a recession, and I was made redundant. So during the 8 months I spent unemployed while looking for work, I volunteered for Centrepoint, a charity in London, and that was in Dean Street in London, and it was a night shelter for young people who were homeless and were were using drugs and involved in the sex industry. So it was pretty tough work, but it really captured my imagination, and I really began to understand the huge importance of engaging with people. Obviously, there's all sorts of things that when you're working with people in addiction that you need to do, but the fundamental issue of connecting with people and keeping a relationship alive really struck me, and it stuck with me, I guess. So anyway, it's a longer story from '93 onwards, but in 2000 I moved over to Ireland. I've worked a number of jobs for Dublin Simon Community and the Homeless Agency at the time, and then DePaul Ireland, the sister organisation of DePaul Trust. So I did a few jobs working for them over the course of around 5 years, but then came to the Ana Liffey in November of 2005. So I've been here just over 10 years. But prior to my getting here, we were established in 1982 by Father Frank Brady. Frank is still alive and well, and his colleague was working with him to establish it, Mara de Lacy, and the two of them set up this a charity called the Ana Liffey Drug Project. And I guess from Frank's experience particularly, Frank had spent some time over in Paris, and he had worked with a large order of nuns there, whose role was to really go out and be with people where they were at. And so they worked with people who were homeless, who were destitute, who were drug users, who were prostitutes, so the language of the day, I suppose. But he really enjoyed that experience. He really saw the value of that. And as I understand it, he moved back to Ireland and looked to do some more work in addiction. So he did a placement at Cool Mind Therapeutic Community. But that was the only addiction service in that at that time. And
mine was it?
Yeah. It was the first addiction service in Ireland, and but Frank really wanted to do which was a higher threshold, if you like, a treatment and rehabilitation service. But Frank really wanted to do that sort of step before that, where you engage with people who are active in their addiction. So that's what they set out to do. So we haven't really moved away from that over the last over 30 years. We're in our 34th year now. our belief in harm reduction and low threshold work, meaning that we work with people with challenging behaviour and tolerate quite difficult behaviour, just to keep that engagement going. Because without engagement, there is no relationship. Without relationship, there's no chance for change. Or there's not no chance, but the chance of change is decreased. So we do that now. We have a drop-in service in our Dublin operations on Abbey Street, and that's open every morning. And we work with over 100 people each morning coming in. We would see around 2,500 individuals across the year, across the three regions we work in, which is Dublin, the Midlands, and the Midwest. Just in terms of our Dublin operations, we would do things like, as I say, drop-in. We would do outreach. We would do case management. So we work on, planning for change in people's lives. So addressing areas like housing and mental health and homelessness and addiction, obviously. So we do that work. We have a stabilisation group. We have a group that prepares people for treatment and rehabilitation, and we would do as a particular piece of work which was assertive case management, which is where we work with the guards with permission from the individual to share information and which is really helpful in terms of overcoming some issues like warrants and things like that. So it's really helpful because they can be barriers to moving on. So, sorry, I'm sort of jumping around a bit, but there's lots that we do in our Dublin service. In the Midlands of Ireland, we would work with both under 18-year-olds and over 18-year-olds. We would do similar work in terms of case management. We would have a drop-in service in Mullingar. And then we would also do work in the Midwest, and we have a team down there of around 5 people. And we would do similar work in terms of the open access service, the group work, having a doctor visit, and outreach. In rural Ireland, the work we do, it's very important to go out to visit people. So you're doing a lot of home visits and meeting people in towns and things because of the sheer geographical distances you're trying to cover. So that's really the Ana Liffey to date. In terms of how the question was around how drugs came to Ireland. Yeah.
It's well documented.
Yeah.
Like I'm just saying, it's interesting that he's mentioned that Kilmine Therapeutic Centre being the first centre, because when illegal drugs, heroin first came to Ireland, it was the inner city of Dublin that first. And it's interesting that Kilmine was actually the first. It wasn't in the north, or the inner city. Like.
Well, it was established. It was established as a treatment and rehabilitation service, but it's definitely the case that geographically speaking, the north inner city of Dublin was where the heroin problem first emerged, and it was devastating to the community. It was devastating because people were dying of overdoses. HIV, AIDS was just emerging, and
there wasn't treatment for AIDS.
No, I mean, you can imagine if you go back to that time, people weren't quite sure what was causing this, and there was a lot of fear. But it really made government focus on a response to. To AIDS and HIV, but really the causes of that. So harm reduction became very, very important around that time globally, in terms of needle exchange, in terms of peer education around staying safe, about finding out about, what caused bloodborne viruses to be spread and how to reduce that risk. And then, of course, obviously things like overdose death, how to reduce the incidences of overdose. So those things were very important. Now, it has to be said that whilst we are absolutely a harm reduction service and a low threshold service,
what does low threshold mean?
Low threshold basically means that we work with people in terms of who may display quite difficult behaviour, and the team, the staff here are very highly skilled at dealing with quite difficult behaviours and maintaining that relationship. We don't bar anybody from our service, but we do sometimes have to reduce the service we can provide. So sometimes perhaps if someone can't visit the drop-in, they may have to come in the afternoon when we're shut and meet the nurse then, for example, or do their case management work off-site, or some way. Always trying to create a creative way of working with people, so that we can maintain that engagement.
Just to talk about today, can you tell me, is it my imagination or not, that the drug problem in Dublin at least, or in Ireland, has actually got worse in the last 10 years or more? And before we talk about the possible solutions to tackle drug addiction or misuse, can you tell me how bad the situation is in general in Ireland in your view? You mentioned Mullingar there. I'm interested in the Mullingar as well. I used to live down there when I was a kid. I don't know many people down there, but I'd be interested to know, just in general, in Dublin, in the whole country, like, is the problem getting worse than 10 years ago, or is it better, or what?
Okay, well, certainly in the last 10 years, the problem in rural Ireland has definitely emerged. We know that you can tell by the drug seizures, you can tell by the people presenting for help with drug problems, and you can tell anecdotally from talking to people who live in towns and villages across Ireland that people can get pretty much anything you can get in Dublin. It's all there, it's all available. So I think that is it worse? It's definitely different. We know that we have a much more complex range of drugs that are available to people. We know, for example, that heroin is still widely available. We know that having had such a difficult time in terms of economic crisis in Ireland, that we have problems that relate back to that. So an increase in mental health issues, an increase in addiction issues, an increase in homelessness, both for individuals and families. So it's a mess. And there's a lot of work to be done. We know that the services have all experienced cuts to the very services that we now depend upon, financial cuts to the services we now depend upon to try and improve the situation and reduce the problems that we have. Because I choose that language carefully because I don't think we really can solve this problem. I think that what we can do is improve the situation, and I think that's an important, I suppose, differentiation to make, because that kind of rhetoric and populist statements don't help. We really need to get to grips with the fact that drugs are here, and are well and truly emerged as a serious problem in Ireland, and that we need to, I suppose, set our goals in terms of how, when we'll talk about responses in a minute, but make sure that we're being realistic about what we can achieve.
You're saying there about cutbacks. I read some politician out where I live the other day talking on Facebook about there's been a significant drop in the number of Gardaí working on their teams for drugs. Is that true?
Well, as I understand it, I read the same thing as well. I have to say the Guards, for in terms of the purpose of what they're trying to do, they are doing a sterling work in terms of implementing the laws that we have at the moment. The truth is that in terms of addiction, policing really isn't the solution. So we have to look at how we're responding to that.
Yeah, I think it makes the most sense to change how the state deals with drug addicts from being solely an issue for An Garda Síochána and the courts to being a socio-health issue. Yes. I know that the last Minister of State for Drugs, Eamon O'Riordan, was in favour of this change. Are we anywhere closer to seeing this happen, Tony? We are. I think we are. I think the fact that we started the conversation, we have to maintain the conversation. When we talk about treating this as a health issue, what people were really referring to was decriminalising drugs, and I think it's really important to just have a little chat about what it means to decriminalise drugs. And decriminalising drugs for personal possession means that it's not that it's legal, it's that the sanction that we implement will not be a criminal justice one, it will be a health-based one. So when people are stopped by the Guards, instead of going to court, this is in the Portuguese model, they go in front of a panel of experts who decide what intervention needs to be
given to the person. If someone is caught with more drugs than allowed, they go down the criminal justice route. So if it's not for personal possession, it's for dealing, then they go down the criminal justice route. If somebody is continuously flaunting the situation, then they face the criminal justice route as well. So I think that it's important for people, because I think people do get confused about when they hear decriminalisation, they think that we're talking about legalisation. Now, legalisation is when you control and regulate the supply, and I think that's a quantum leap for Ireland. I think that there are benefits clearly to that, but there's a benefit cost analysis people will have to look at. But we're not anywhere near that discussion at all. So I think in Ireland, my understanding is that the next drug strategy hopefully will include, to continue the journey towards this idea of a health-based response to particularly drug use.
Yeah, the Diagnostic and Statistical Manual of Mental Disorders, or DSM for short, actually diagnoses addiction or dependence on drugs, including alcohol, as being an illness. I would agree with that. It's not something I think most people think of when they think of drug addicts, but if you actually think about people who are addicted to heroin or cocaine or alcohol as suffering from an illness, it actually, I think, really changes your view of them, I think. What would you think about that?
Well, I think that it's one way of looking at it. I'm not against it at all, the idea of it being a disease or an illness. What I find is that when people are experiencing addiction or drug dependency or using drugs in a chaotic manner, they're desperate to understand what's happening to them, and they're desperate because it's a very painful and traumatic experience for them, and it's a very traumatic experience for the people around them, their loved ones. And so you've got the individual and you've got the family trying to understand what is happening for that person. And I think, because there are different ways of thinking about it. There is the disease model. There's the idea of a gene that causes this. There's the idea that it's learnt behaviour, maybe due to trauma. So these are social constructs, effectively, where people try to understand what's going on for them. And I'm happy with anything that helps somebody understand what's going on for them. Okay, so I don't particularly prescribe to any way of thinking. I'm just happy that if somebody really understands, can make sense of what's happening to them, and then, really importantly, what they do next about it. So if they can't stop, are they being safe in their drug use? If they have the strength and the support mechanisms that really what you need to get to around you, is what they believe about their drug use, in terms of understanding it, is that helpful in terms of, the next steps, what they do next about their dependency, their drug use, the disease that they think they have. So I hope that makes sense. It's certainly not against any particular school of thought. It's just that my experience is that different people believe different things about what's happening for them. For example, AA and NA works very well for some people. Narcotics Anonymous. So it works very well for many, many people, but it doesn't work well for everybody, or it doesn't work for everybody. So you can't just exclude those other people. How do they see, the experience they're going through, and what supports do they need? So I think there's different things happening or different ways of thinking for people, and it's all okay.
Yeah, just to give you my experience, when I was a teenager, for about 4 years, I smoked cannabis fairly regularly, not very regularly now. I did ecstasy on the weekends for a year, and I wouldn't describe what I went through recovering from them as being an illness. Certainly they affected my brain, and they are very damaging drugs, but I wouldn't say cannabis dependency, which I would have had when I was a teenager for 4 years, as being an illness. It doesn't feel to me to be an illness. And same as ecstasy, you can't get dependent on ecstasy, you can get dependent on the cannabis. Sure. But then, about 10 years ago, I developed a drink problem, and I went to loads of AA meetings, and I'm off drink over 5 years. If you go to AA meetings, they'll tell you that alcoholism is a disease, but I think that a lot of people in the public health system, like doctors, nurses, psychiatrists, don't agree or understand or have thought much about that disease model. And it just makes sense to me if alcoholism is a disease, and there are exceptions, I suppose, like, and one size doesn't fit all. A lot of people, AA is not suited to them. I haven't got to AA in over 3 years. Yeah. But I think if it makes sense if alcohol is a disease, and I think it is, and I think I still have that illness, even though I'm off it over 5 years. I think that heroin and cocaine will be illnesses or diseases, whatever you want to call them as well. I think it makes you look at people differently if you think they have an illness. And it's not just a justice issue. Like,
sure, but it's complex. I mean, there's physical addiction and there's psychological addiction. Cocaine is not physically addictive; it's psychologically addictive. It's habit forming. So, you know, you look at it that way, and there's already a difference emerging. You mentioned ecstasy there a moment ago. I think there's two types of drug users, broadly speaking. There's people who take drugs because they want to, because it's recreational, as you described there a moment ago, and then there's people who can't stop taking drugs. And you can, just because you're a recreational drug user does not mean that you will become an addicted drug user, but you might. Okay, and so people need to realise there are risks associated to drugs, and that's something that we always must consider. You know, the drugs are not safe, but they're not all as dangerous as each other. And certainly, I think it's really interesting. I think that you know, people need to have credible messaging, things that they believe. Because the just say no messages of yesteryear simply didn't work. So we know that if you tell people don't take drugs, it doesn't work. You know, some people may listen to that, but predominantly people don't listen to that. People do take drugs, not everybody, but people do take drugs, and you have to talk to them about the risks that they face, the harm they may do to themselves, and that they are informed about those risks. And then, you know, if they want to stop, what options can you give them? What help can they get? What are I suppose, in terms of, protective factors, you know, particularly for young people, you're talking about their peers, you're talking about their teachers, and you're talking about their parents, you know. And we know from research that any deficit in either one of those areas means that the young people are more likely to have a difficulty, maybe early school leaving, the onset of drug use, etc. So you know, my thing for working with young people would be look, target those people who have those particular, you know, that kind of particular set of problems, and support them, you know, because really when you get into it, not everybody will be as at risk of problematic drug use as everybody else. So you really need to focus your resources.
Yeah, we can come back to the talk more about that in a few minutes, Tony. I've heard, just to go back to we were talking about a few minutes ago, I heard a lot of talk in the last year or so about the government bringing in injection rooms, and I agree that this would be a helpful step. But am I right? Well, I think you just said this already, but it's just one policy that needs to happen, isn't it, amongst a kind of sea change of government approach?
Yeah, I think so. I think that, you know, there's no silver bullet for addiction in Ireland. The issues are complex and far-ranging, you know. The supervised injection facilities we've been lobbying for since 2012, so we're well versed in the benefits and of that type of service delivery. I worked in the Sydney injecting facility for 2 weeks in March of 2015. It was a very good experience. I know that people might struggle with the idea that you're in a room with 16 people and they're injecting themselves with illicit drugs, but they would be doing that anyway in the streets and in the alleyways of Dublin. We know that we have a problem, particularly in Dublin, with around 400 people in any previous month. From the stats we can figure out, we think a conservative estimate is around 400 people. The number could be much. Doing whatever, injecting drugs. So it could be, I mean, we'll go back into that in a second, but just to say that 400 people is a conservative estimate, could be much more. We need to get those people out of those alleyways for their own safety. They are filled with shame about the behaviour, about what they are doing to themselves. The research shows that, you know, people have been asked how they feel. They feel that there's a huge amount of shame attached to it. They hide away, and these are barriers to progression. But you get people into supervised injection facilities, all that's gone. Okay, not only are they physically safe because there's a nurse nearby and other staff, but that final kind of barrier is gone as well. That feeling of shame. So you talk about it's just easier to engage with people, as I mentioned before, to talk about the issues that they have there and then, to make sure that they're safe. And the evidence is quite clear that if there was a European drugs report just recently published. It gets published every year, and they're very clear that if you have supervised injection facilities in an area where you have a problem with public injecting, you get people through to treatment and rehabilitation faster than otherwise. So I suppose that it is one type of service provision that we don't have that we need in Ireland, and I'm very happy to say that the government are still working towards changing the law. They say that it will be changed before Christmas. So the legislation, which when enacted will allow for the existence of supervised injection facilities, that will begin its journey through the Oireachtas, through the Dáil, through the Seanad in September. I'm hoping that
next month.
Yeah. So there'll be a strong focus, and obviously there'll be debate. But I do hope that they'll know, that this won't be used for party politics. This is a very, very serious situation we have in Ireland in terms of public injecting, and we need to get those services up and running as quickly as we can now. We've done the legwork in terms of lobbying, in terms of informing the debate. Our politicians have picked up running with that, and we need to make sure that we get those services open as quickly as we can once the law has changed.
Is it true that Aon O'Riordan was the first minister, he was a minister of state, but first minister for drugs that is actually in favour of the changing it from being solely a justice issue? From my experience, Aon was O'Riordan when he was Minister for Drugs from May of 2015 onwards, was very clear, very progressive around his thinking around drug policy. So he was supportive of decriminalisation, and he was supportive of the supervised injection facilities. He came and visited the project. He came and walked the streets with me, and I showed him where people were injecting and such. And he was very vocal. He was very clear in his argument as well. I thought he was very compassionate towards people who have drug problems. Yeah, he's not in the Dáil anymore. He's a senator now. Are there other people are there other people who agree with him in the Dáil and the Seanad, and can we be confident that I know the drug or the injection facilities are coming in hopefully at the end of the year or next year, but can we be anyway confident that the debate is going to move on and it's going to be just decriminalisation?
Well, that remains to be seen, I guess. The most important thing that I learned in the last little while is that only with leadership will decriminalisation move forward. If you imagine that there's a lot of debates about how to best address the drugs issues and addiction issues in Ireland, there's lots of evidence out there, and people are, arguing which way to go. When you're the leader, when you're the minister and responsible for these, you have to listen to all the arguments, and then you have to make a decision on the best available evidence as to which way you go. And Aon had very clearly been supportive of decriminalisation, as were other politicians. But I suppose it will remain to be seen as to whether we see that progressing. But I do believe it will. I actually do. I think that the debate will continue. There are people in the voluntary sector and the community sector, politicians, senators, local councillors, etc., that do believe that we need to change the paradigm that we're working within, from a criminal justice one to a health-based one. Okay, Tony, that's great. I just want to quickly ask you: is there do most people who work in the sector you work in, the addiction sector with drugs, agree with you that there should be decriminalisation? Most people do, but there are voices of dissent about the issue, which I respect their point of view. However, the evidence is quite strong, quite clear that treating drugs within the idea of a health paradigm as opposed to a criminal justice one is very strong. We're looking to implement progressive drug policy because the drug policy that we have at the moment simply isn't working. We, as the beginning of the interview, you talked about, has it got worse in the last 10 years? Well, I think most people would say that it has. But I think the reason it has is because policies aren't particularly working, and also we're faced with just an unending array of drugs becoming available through this illicit drugs market. So we need to think differently and do things differently.
Yeah, just the last question on this debate about decriminalisation. Say if someone is doing a drug on the street and they have a personal amount just for personal use, sure, and a guard comes across them, would the guard still be able to confiscate the drugs off them?
It would all depend on the model that's implemented, so it'd be hard for me to say, but I mean that could be factored in. For example, so one of the issues that people think when you say you want to implement a supervised injection facility and allow for the possession of drugs to be legal on site, the question immediately that people come back with is, well, what about when they're walking to and from? Well, the answer to that is that, you know, I've been in Sydney. I've seen people walking towards the supervised injection facility past police officers and walking in, and you know it wouldn't take much to realise that they had drugs on them, obviously, and that was fine. And I've also seen people who were walking towards the supervised injection facility in Sydney who were acting out, if you like, being loud, maybe looking suspicious or looking like they're dealing. And being stopped by the police and being processed under the laws that they have there. So, you know, I think, you know, for me it's about that, you know, that on that particular example, it's about behaviours. It's about being responsible as a drug using person, you know, and respecting the environment. Otherwise, you'll expect to be stopped by the guards and processed in another way. But that's not under decriminalisation. That's the supervised injection facility. That's that example.
Is there any creative work you do with people here, like kind of like art or anything?
We have done over the years. Yeah, we have done over the years. The stabilisation program here would do some use some creative some artwork and things like that. But over the years we've had art workshops and different types of workshops. But nothing particularly at the moment that stands out. I mean, the stabilisation program would do some work like that. Yeah,
kind of occupational therapy kind of.
Yeah, mostly it's to do with people learning about their behaviours and triggers and such. But nothing particularly at the moment. No.
Okay, Tony, what is your message, if you were to shorten it down to a couple or few minutes, to our listeners, including any politicians if they're listening, and indeed people with drug problems or people who think they may have a drug problem? What's the best way to stay involved and up to date on the debate about drugs in Ireland, including alcohol, and in Ireland and internationally, in your view?
Well, I mean, the Ana Liffey is quite clear, strategic plan-wise, around the implementation of the supervised injection facilities to address public injecting in Ireland, but particularly in Dublin. I say in Ireland because I'm always aware that my colleagues in Cork have identified that they wish to implement supervised injection facility in Cork City. So there's a problem in other areas. I would say that there is in terms of our strategic plan, we have recognised that there's a need for accessible residential treatment for people, so we need that as quickly as possible, because when it comes down to it, treatment and rehabilitation is part of the response to improve and reduce the problems that we have in Ireland. The discussion around decriminalisation should continue at pace, and we should move towards that health-based paradigm that we talked about in the interview. So that's very important. Okay, so in terms of people who may have a drug problem who are listening, there is a website that we manage here, drugs.ie, drugs.ie, and you will find a services directory there. And that is up to date and is right across the country. And so wherever you may be listening, you can go there and see what kind of services are available. But not just that, there's a lot of information on there around different types of drugs and different ways to keep yourself safe or to look for support. Because, some people want to stabilise their drug use and some people want to abstain from drug use. And there's a range of options in terms of how you can respond to that. So drugs.ie, I'll keep saying it, drugs.ie is the place to visit. Yeah, I think that also in terms of staying up to date on the debate, I find social media very useful. I mean, certainly, Darren, you and I arranged this through Twitter. So I think that's helpful, but you have to make sure. But there's a lot of noise out there in terms of what's around. So there are very good if drugs.ie will post all the news and such, so you can visit that. You can follow the Ana Liffey Drug Project on Twitter. You can follow myself on Twitter. And what we try and do is post evidence-informed papers, news articles, etc., just to keep people up to date. This is a global issue, so this, you can take it as local as you like, as national as you like, or as global as you like. But I think really, you're looking for websites and information that are evidence-based. The EMCDDA, the European Monitoring Centre on Drugs and Drug Addiction, has excellent information and research available on their website. So visit that as well, and you'll find plenty of information there.
Yeah, the great thing I find about Twitter, I only joined Twitter about 3 years ago. I think it's great. You can engage with people, you can follow people, and engage with people like yourself, and in this sector, in all different sectors from around the world. It's amazing the opportunity it gives you.
It certainly does. I mean, there's things. I mean, this interview was the genesis for that was Twitter, and other relationships. Interprofessional relationships have been sort of built up from social media. Facebook, there's other social media that you can use, and then of course there's things like LinkedIn. If you're a professional in the area, there's another way of networking and sticking with people. So I think it's an interesting time we live in terms of the social media side of things. It's only early days, really.
Yeah, I think social media is great, and I had problems over the years with drugs and drink, and it wasn't for social media. It helps me hugely to be creative on social media. It gives you a great sense of satisfaction. I don't necessarily mean talking to people, but creating videos on YouTube or podcasts. You get great satisfaction out of it,
Absolutely, it's a great tool. But of course you can engage. People can engage with it. They can say, I don't agree with that, or I do agree with that. They can formulate an opinion based on. There's so many good, great thinkers out there that are engaged, particularly with Twitter. Actually, they're particularly engaged across the world, as you mentioned a moment ago. Whether it's in Australia or the US or wherever it might be, and you can talk to them directly. So it's a great tool. Yeah.
Okay, Tony, it's great talking to you. I'll be talking to you again, hopefully by the end of the year, early next year. Hopefully I won't need to talk to you, but hopefully there'll be a lot of progress on the supervised injection rooms. So thanks very much, Tony. Right?
Thank you very much, Darren. Thanks for the opportunity. Thank you.